So 6th January was session 3.
Yeah, 6th January was session 3.
Session 3 and today is session 4.
Yes.
Okay. Okay, all right.
Are we good to go? Good to go?
Yes, yes. I'll open the room and I'll make you the host so that you can do the questions.
Polling and all. Yeah. I think
Yes.
already done by Bhavish, I think.
No, because I had to go live. So I again claimed the host rights.
Oh,
Because
okay.
then without that, I can't go live on
Oh,
YouTube.
okay, okay.
Okay. So I'm making you the host now.
Okay.
So all my rights will be withdrawn. You will get the polling section now.
Okay.
Can you see the polls option?
Yeah, I can see it in the top.
Yes. Okay, perfect. So you can begin whenever you want. I have opened the room.
Okay. I think it's already time. It's 8:30 right now. So let's, I think we'll begin the session.
Begin, or do you want to wait a couple of minutes till more people join?
Okay.
Whatever is your convenience.
Okay, I'll just begin. I'll just start with so that it's. I think five questions are just revision questions to make sure that the people are like following us.
Okay.
Uh,
Okay. All right.
by the time people will trickle in.
Okay. Sure.
Okay. So good evening, everyone. I'm Dr. Ahmed Subair, Assistant Professor in Neurology at MES Medical College in Kerala. So welcome to yet another session of Fine Neurophilia series. This is the module 4. We are dealing with dementia advanced. So if you are with us in this series of Fine Neurophilia, last time we were dealing with dementia basics. Last time I had told you that dementia is a bit difficult topic to deal with. If you had revised the last module, you would have understood that it is a bit difficult, but it is easy to get easy if you had understood the concept well. And if you had revised it, this module is going to be very, very easy. And this is going to be a high yielding module for your exams. And I had informed you that there would be a bit of a question session, that is a quiz session before we go into the topic proper. So with that, I'll go to the topic. But before that, I would really thank Dr. Sudhir Kothari sir and the fine team for giving me this opportunity for presenting and teaching in this forum, and hope all the aspiring neurologists understand the importance of this opportunity being provided to them, and make the best use of it, because it is being given to them free. Don't misunderstand and misuse it. Make best use of it for their exams. And I'll tell you again and again that it's not a capsule form of the topic, that is stroke was done, dementia was done. It's not a capsule form. It is to make you read Harrison and Bradley topics, to make palatable that the difficult concepts very easy for you when you read the textbooks, and also to emphasize the importance of reading Harrison and Bradley for the preparation of your exams, and also to keep you in correct track till your exams. With that, I'll just want to make sure how you were preparing for the past 1 week after the dementia basics, whether you are reading your Harrison well, you are following us in your preparations. So let's see how you are doing. So with this, we'll start the poll. So let's see the first question. So first question is what is the typical duration of the, can you see the questions? So what is the typical duration of the symptomatic Alzheimer's disease? I have taken this question directly from Harrison. So I hope you can answer this question. What is the typical duration of symptomatic Alzheimer's disease? So is it because nobody is able to answer this question? Nobody is. Are you able to attempt this question? I'll relaunch the poll once again.
Yes, anybody facing difficulty in answering, you can please mention in the chat or the Q&A.
I have again relaunched. I think now it's clear. Yeah, yes. This question is directly taken from Harrison. Such one-worders would again and again come in your question, and this is one of the repeat questions in NEET exam. What is the typical duration of symptomatic Alzheimer's disease? Yes, most of them have answered it correctly. It's actually 8 to 10 years. So I forgot to give you the options. So 1 to 2 years, 2 to 4 years, 4 to 8 years, and 8 to 10 years. Most of them have answered correctly in the polls. The problem is in YouTube video, the options would not be coming correctly. So this is the taken from Harrison. So next question would be, in patients with family history of Alzheimer's disease, how much percentage has autosomal dominant inheritance pattern? So in family history of Alzheimer's disease. So hope you can see family history of Alzheimer's disease, how much percentage of has autosomal dominant inheritance pattern? Yes, most of them are have read the textbook well. These kind of numbers and percentages are repeatedly asked, these are numbers which we usually miss while reading. Just to make sure how well you have read the textbook, Harrison, I have just put this question. More than 50% have answered correctly. I think those who haven't read should go back and read the question, Harrison. But if they haven't read also, please try to make a point that you attempt the question. If you make a mistake now, it's not a problem. But make a point that you make a attempt right now. So it is actually 2%. So next, so last time we were discussing regarding all the genes, that is ApoE, APP, that is amyloid precursor protein, presenilin 1, presenilin 2, etc. These were the genes. So this is, which of the following structures is responsible for the production of serotonin? Which of the following is responsible for the production of serotonin? So which one of the following do you think is responsible for the production of serotonin? So all these degenerative diseases results in degeneration of certain structures, and these structures results in decrease in certain neurotransmitters, decrease of certain neurotransmitters. So locus coeruleus, what do you think? If locus coeruleus gets degenerated, which neurotransmitter is decreased? Nucleus basalis of Maynard, if get destroyed, which neurotransmitter get decreased? Dorsal raphe nucleus. And what is the function of pedunculapontine nucleus? So I'll tell you one by one. So the answer is dorsal raphe nucleus. If it gets destroyed, then serotonin will be there will be decrease in serotonin. Locus coeruleus, it is concerned with norepinephrine, and nucleus basalis of Maynard is concerned with cholinergic. It's choline, acetylcholine, and pedunculopontine nucleus is concerned with gait, and also it associated with REM sleep behavior. REM sleep behavior. So these are all taken from Harrison. This 20th edition, latest edition of Harrison. So have you heard of this disease, Nasu-Hakola disease? If not, please make sure you read your Harrison very thoroughly. It's not a rare disease. It is rare. I agree. It is a rare disease. I agree to that. But you shouldn't miss it, because try to answer this. Nasu-Hakola disease is associated with which of the following mutation? All these mutations are very rare, but it is not any out of syllabus question or not, it is taken from Harrison. Nasu-Hakola disease is associated with which of the following mutation? It is associated with dementia, and dementia associated with bone cyst. So this kind of dementia with bone cyst is otherwise called Nasu-Hakola disease. It is associated with a particular kind of mutation, and it is mentioned in Harrison. And we had a disease, this kind of mutation present in a patient. We had this patient having a particular dementia with a strong family history. When we did the genetic testing, we found that the patient was having this kind of particular mutation. So whether it was a clustering mutation, PICAM mutation, TREM2 mutation, or a CR1 mutation. So actually, this is due to TREM2 mutation. So TREM2 mutation is the most results in Nasu-Hakola disease. So this is this is given in page number 3111 in latest edition of Harrison. So this question I thought I will put because just there in Harrison, just to make sure you have whether you have read Harrison or not. Just to depress you, I have put this question so that you read Harrison. This is to make sure that to show you the importance of Harrison. I have just put this question. This is not that important. Presentence. We have discussed in the last class that the most common cause of family, that is early onset Alzheimer's disease, was presenilin 1, and second and presenilin 2. So the presenilin genes produce the protein presenilin, and this is homologous to the nematode protein, that is cell 2. So which nematode has the cell 12? Is it this Caenorhabditis, Gnathostoma, Angiostrongylos, or Hemophysalis? Sorry. So just so what do you think the answer is? Yes, everyone has got it correct. So these 5 questions which I had put is all taken from word by word from Harrison, just to make sure that you are reading Harrison. As you know, for NEET, you need to know word by word of Harrison. And later, at this point of time, because you have got 7 to 8 months for your next exam. So later, if you want to study extra for your institute exams and all, you can build on this after reading Harrison. You can build on by reading Bradley or other books to crack other institute exams after reading Harrison. So that was my point. That's why I asked these questions. So the answer is Caenorhabditis elegans. So what is Caenorhabditis elegans? It's just the roundworm. So in studies, we look into these kind of nematodes in case of studies. So that was regarding the 5 questions. So so if you had got all the 5 questions correctly, then you have completed your dementia well. But if you have got even one answer wrong, please go back and read your Harrison thoroughly once again. It's not that I had put this kind of silly questions, like last question was a silly question, but I just wanted to make a point that you have to read word by word of Harrison thoroughly. It's not that these kind of questions don't come. This kind of questions can come. The clinical aspect also, like last session, we had emphasized the important points of dementia very well. So last time we had discussed that dementia in last part of dementia. Last time we had seen that in dementia, there are particular areas. In advanced dementia, all the dementias would look alike. But in case of, while taking the history, if you see, in case of Alzheimer's disease, the insult initially starts in the temporal lobe. Then later, the insult increases and then affects the frontal lobe. But in case of frontotemporal dementia, it initially starts in the frontal lobe, then affects the temporal lobe. And in case of posterior cortical atrophy variant of Alzheimer's disease, the initial insult starts in the occipital lobe, and later it extends into the frontal lobe. So these are the so next question, let's see. Which one of the following inclusion bodies are present in Alzheimer's disease? Is it Pick's bodies, Hirano bodies, Dirk's bodies, or Bunena bodies? So try answering this question. Which one of the following bodies are present in Alzheimer's disease? Yes. Okay. So it's actually Hirano bodies. So where do we get this Pick's bodies? Pick's bodies are found in Pick's disease. Pick's disease is the older term for behavioral variant of frontotemporal dementia. And Dirk's bodies are found in malaria within the brain. And banana bodies are present in the anterior horn cell. Anterior horn cell in case of amyotrophic lateral sclerosis. So these are all inclusion bodies. So you can see this chart. So Negri bodies are also found in brain in case of rabies, and Lewy bodies are also present in Alzheimer's disease, also in Parkinson's disease, Lewy body dementia, etc. Lafora bodies are also seen in brain in case of Lafora disease. These all can come as MCQ questions. So this is a challenging question which I'll ask you. You can read the question and try to answer the question. Read this question carefully. A 56-year-old female presented, she is right now in my ward, presented because of progressive visual difficulties. She had multiple visits to her ophthalmologist, who told her that her vision was perfectly normal. Her husband, who was concerned about her, was aware that she was having some problem with her vision. She was late. Then every time she goes to her ophthalmologist, she says the ophthalmologist tells that her vision is normal, but she used to lose her way. She later started to forget her things. She had some episodic memory impairment, etc. And when she was admitted in our ward, she's right now in our ward. Just see her video. I'll just reduce the volume. She has difficulty even in finger counting. She is unable to tell the numbers correctly, and if you see, she's unable to tell even the numbers very close to her eyes correctly. Some colors she is able to identify correctly in front of her. Only moving hands she is able to see correctly. That too very close to her eyes. And when asked to catch hold of her hand, catch hold of the examiner's hand, she is overshooting. That is, she is trying to touch the examiner's tie or shirt, but she doesn't have any cerebellar signs. And this is another video. She is walking around in the house, touching through the walls. She's trying to put the switch after touching the wall, then reaching the switchboard, then switching on the light. She's going to the bathroom, first touching the wall, then reaching the door, then going to the bathroom. Then while walking, but if you see, obstacles were put, but she's able to overcome the obstacles without hitting. And the one history they were saying was that while eating food from the plate, she was concentrating only over in the center of the plate. If chicken curry or a fish curry was kept over the side of the plate, which is usually done like that, in the center of rice is kept, by the sides the side dish is kept. She won't notice the chicken or the fish kept at the sides and eat only on the food concentrate in the center. And later she was evaluated, and MRI brain was taken, and this is the MRI brain of the patient. So what is your diagnosis? So this is question number 7, I guess. Yes, question number 7. So you have seen this patient who started off with visual difficulties. Later on, she had memory impairment. Yes. So it's clear cut answering. You have all got, but yes, some have a different opinion. But everyone should have an opinion because all of you are going to be a neurologist. So such a patient comes to you. Yes. Excellent. Actually, all have got varying opinions. It's well and good. Okay. The most of them, 80% of them have answered it as posterior cortical atrophy. And 14% have answered as dementia with Lewy body. And 5% have answered as Creutzfeldt-Jakob disease. So I'll tell you, and nobody has answered as a typical variant of AD. So all of them are correct in a sense, because it is not a typical variant of Alzheimer's disease, because all of you know that it starts as an episodic memory impairment, which starts episodic memory impairment is usually a problem with the mesial temporal lobe. So it didn't start like that. It started as a visual problem, which is a problem in the occipital lobe. So dementia, posterior cortical atrophy usually starts in the visual, that is in the visual cortex, that is the occipital lobe. So that is the most likely possibility, but it can be even a dementia with Lewy body. That is also starting with the occipital lobe. That is also a likely possibility, but that usually has other associated features. Dementia with Lewy body will have a fluctuating cognition, which we will come and which we'll discuss later. That is also a high likely possibility. Also regarding Creutzfeldt-Jakob disease, there is a variant called Heidenham variant. Heidenham variant, which also starts with visual problems. That Heidenham clinical variant also starts with a visual problem in case of Creutzfeldt-Jakob disease, which has a rapid progression, and rapidly this visual problem will initially start as a visual problem and then progress into a dementing process. So all of you have answered the answered correctly. But for this patient had a about 2 years history and now has progressed into a memory impairment. So this is actually a posterior cortical atrophy. And for posterior cortical atrophy, it could be either an Alzheimer's pathology, it could be a tau pathology, as in case of a CBGD, that is a corticobasal variant, or a PSP kind of pathology. For us, for this patient, it is most likely a Alzheimer's type of posterior cortical atrophy. So Alzheimer's, we have studied it is a frontal variant, posterior cortical atrophy variant, or a logopenic variant. So this case is actually posterior cortical atrophy variant. So that was one type of Alzheimer's disease we have discussed. So since the posterior cortical, that is both the bilateral posterior areas are affected, this patient will have balance syndrome. So what we found was that the patient was having optic ataxia, that is misdirected movement. Patient can have ocular apraxia and simultagnosia, that is patient can only see one object at a time. That is why when patient was eating, she had difficulty in attention. She has difficulty in directing the attention. So she was not seeing what was on the either sides of the plate. She was seeing only the things in her first view. She was not able to attend to the curry in the periphery of her vision. That is dorsal simultagnosia. Also, the patient will be having Gertzmann syndrome because of angular gyrus and supramarginal gyrus involvement. So that was regarding posterior cortical atrophy. That is a variant of Alzheimer's disease. So which of the following is or are a feature of frontotemporal dementia? Try to answer this question. This is the 8th question. Which of the following is the or are the features of frontotemporal dementia? So everyone, please, everyone who is viewing this session, try to answer this question. I want everyone to answer this question so that you all actively participate. Yes. Okay. Actually, answer is all the above. Okay. So frontotemporal dementia is basically mainly divided. There are many varieties, mainly divided into behavioral variant, semantic variant, and non-fluent or agrammatic variant of frontotemporal dementia. The most common genetic, as we have seen in Alzheimer's disease, we had many genetic causes. So in familial frontotemporal dementia also, we have about many genetic causes. So which is the most common genetic cause of familial from frontotemporal dementia? Is it C9orf? GRN is progranulin. MAPT is microtubule associated protein, valosin protein, etc. So have you heard this C9orf somewhere else? You must have heard. So what do you think is the, so this is question number 9. Try to answer this question. Question number 9. The most common genetic cause of familial frontotemporal dementia. We discussed in one question in Alzheimer's disease, that is while we were reviewing the Alzheimer's disease, 2% of Alzheimer's disease is autosomal dominant. In case of frontotemporal dementia, about 10 to 20% will be autosomal dominant. So the most common genetic cause of familial frontotemporal dementia is, yes, exactly. It is about 95% have answered it correctly. It is C9orf. It is a high yield area. That is, many questions can be asked from this area. So you need to know this area very thoroughly. So many genes are there in frontotemporal dementia, and it's a highly likely asked topic from this area. So you need to know this area. C9orf, GRN is progranulin, and MAPT is the microtubule associated protein. So last time we have seen regarding microtubule associated protein. Microtubules are areas within the areas within the neuron which are concerned with the anterograde and retrograde transmission of the within the neuron. So the C9orf has got hexanucleotide expansions which are concerned with these kind of mutations, and it is associated most likely with ALS. So this FTD with ALS, most likely combination of mutation is C9orf, and this GRN and MAPT, most likely it is associated with FTD with Parkinsonism and less likely with ALS. So remember this picture, that is C9orf with ALS and GRN with MAPT with Parkinson's disease. And last time we had seen these kind of pipes carry within the neurons the anterograde and retrograde transmission, and this is connected with MAPT mutation. And this progranulin, if there is a homozygous mutation, this is associated one disease that is called neuronal ceroid lipofuscinosis. This is also there in Harrison. This could be asked. So homozygous mutation in progranulin could result in neuronal ceroid lipofuscinosis. This is a constellation of about many diseases. You must have heard of Cuff's disease, Santovarni's disease, etc., etc. This is due to this progranulin, homozygous mutation in progranulin can result in this neuronal ceroid lipofuscinase, NCL, can occur. So lots of questions are there. And apart from these main 3 mutations, multiple other mutations are mentioned in Harrison, that is VCP, TANK, etc., etc. Just need to know some are there important. This last 3, TAR-DP are and FUS, especially TAR-DP are right now under lots of studies are coming from TAR-DP, that is TDP43. Lots of studies are there. So that was regarding genetics of FTD. So we had last class, we had studied regarding genetics of Alzheimer's disease, very important. Similarly, genetics of FTD is also very important. So this is one more question, clinical question. A 63-year-old male had developed language problems where he, instead of calling a car, he called the car as a device for moving around in a place and was using filler words. For example, asking for a jug, he was telling, take that, take this, etc., etc. And later this progressed into some memory impairment and some behavioral problems. So what do you think the diagnosis is? He was not getting words for the things. For example, umbrella, he was not getting the word, etc. So specific words, names, etc., he was not getting. So what is the diagnosis for this? So question number 9, I'll launch the poll. Try to answer this. Whether it is a non-fluent or agrammatic variant of FTD, semantic variant of FTD, behavioral variant of FTD, or a logopenic variant of FTD. So he was not getting the names. So in Malayalam, it will be like adu konduva, idu konduva, idedukku, adedukku. In Hindi, it will be ye leke aana, wo leke aana, ऐसे बोलेंगे. Tamil, adu konduva, idu konduva, ऐसे बोलेंगे. They won't be getting words, specific words. It will be really frustrating for them as such. So what do you think it is? So this is actually exactly, most of them have got it correct. It is actually a semantic variant of FTD. So semantic variant of FTD is another form of frontotemporal dementia. And it is actually semantic knowledge. They won't be, there will be impaired word comprehension and object naming. So it will be a fluent speech with spared repetition. Repetition will be spared. And in case of progressive non-fluent aphasia, there will be spared, object knowledge will be spared, and word comprehension would be spared. But the grammar will be affected in case of progressive non-fluent aphasia. And in case of semantic variant, one more thing you have to know is about surface dyslexia. This is a bit difficult. This is for institute exams. Surface dyslexia is something like, in case of telling kernel or pint, you usually pronounce as kernel. It is not colonel. It's kernel. Pint, it is not pint. So usually that this kind of semantic PPA patients, they will pronounce as colonel or pint or pint. So this is called surface dyslexia. This is usually seen in semantic progressive PPA. And I'll tell you about a patient who was shown this picture and asked to describe this picture. And while describing the picture, what he wrote was this. He wrote that there is the boat in the water. The boy was flying kite. The girl was in the sandcastle, and he was having lot of grammatic language error. So this is a case of agrammatic variant of PPA, or otherwise called non-fluent PPA. So where is the atrophy maximum in this patient? So don't think that it is a tough question and all. This has been clearly written in Harrison, clearly given with picture as well as explanation regarding where the atrophy is. So try, if you have read through, you would be able to answer this question. Try to answer this question. So in case of an agrammatic variant of PPA, there is a specific area in the brain which gets atrophied. So try to answer. Okay. Okay. Yes, actually, most of them have got answered it correctly, but few have got confused whether it is left anterior temporal or left inferior frontal gyrus. The other two is actually the area where the behavioral variant gets affected. So behavioral variant is actually in the orbitofrontal. So last time in the initial class, we have discussed that in the orbitofrontal is where our inhibitive, disinhibitive, or social functions are residing. So if it gets affected, the patient will be having very disinhibitive behavior. That is usually what is seen in behavioral variant of FTD. So behavioral variant of FTD, there will be severe atrophy of the frontal part. In semantic variant, we have usually the left anterior temporal. This is the left side, and this is the left anterior temporal region gets atrophied. And in the agrammatic or non-fluent PPA, there is left inferior frontal gyrus. It's clearly, we can see here, left inferior frontal gyrus is atrophied. This is the picture taken from Harrison, where we can see that the specific variants of FTD has specific areas of affection. And this table is taken from Bradley. So the early appearance of Parkinson's disease, Parkinson features in association with fluctuating alertness, visual hallucination, or delusional misidentification suggest. So this one we had just brushed through and discussed in the previous when we were discussing our case. So this is much easier for you right now. I hope nobody makes a mistake in this answering. So the Parkinsonian features are there. There is fluctuating alertness. There is visual hallucinations. There is delusional misidentifications. So we'll just go through what are delusional misidentifications also. So somebody mistook it for CJD. It's not CJD. So yes, most of them are answering correctly. So Parkinsonism features with fluctuating alertness. So there is a criteria for this disease. So we'll discuss that too in a brief. Just okay. Previously, we used to include neural sensitivity also for this. So what we are dealing with is actually dementia with Lewy body. Most of them have answered it correctly. So dementia is there, which will include attention, mainly attention problem, and as well as visuospatial problems. There will be fluctuating cognition. That is, there will be delirium, and on top of it, there will be visual hallucination. And as you know, it is a type of a Parkinsonism syndrome. That is alpha synucleopathy is there. And there will be REM sleep behavior. Then there will be neural sensitivity. So such a patient, when the patient becomes restless, if you give haloperidol, the patient will become either restless, more restless, drowsy, or his Parkinsonism symptoms will increase. And on top of it, the patient will have other findings. So this is the classical feature of a dementia with Lewy body disease. And in the question, something was there, patient will be having misidentification syndromes. So what are the misidentification syndromes you know of? One is the Capgras syndrome and the Fregoli syndrome. Capgras is one where a close family member is replaced by a stranger. So, and Fregoli is the other way around. So, as you know, even Parkinson's disease can have dementia, and also dementia with Lewy body is always having a dementia. So, how will you differentiate between these two? So, there is a criteria. There is a time criteria. So, PDD, that is Parkinson's disease dementia, is distinguished from dementia with Lewy body by the presence of Parkinsonism preceding cognitive decline by at least how many time period? So try to answer this question. So what do you think is the time period that Parkinsonism should precede the cognitive decline for at least dash to be called as Parkinson's disease dementia? So the answer is actually 1 year. So Parkinson's disease should precede more than, there should be more than 1 year of Parkinson's disease, then followed by dementia to be called as Parkinson's disease dementia. If so, PDD is distinguished from DLB by presence of Parkinsonism preceding cognitive decline for at least 1 year. And as we know, 80% of Parkinson's disease will develop dementia. So, and FDA has approved rivastigmine as the drug, that not donepezil, rivastigmine as the drug of choice for Parkinson's disease dementia. This is actually taken from Bradley. So rapid progression of dementia over a few weeks or months is there. So there is rapid progression with rigidity and myoclonus. So what is your diagnosis? It's a quite straightforward question. If it comes, there should be no confusion. So what is your diagnosis in such a case? Yes, all have answered it correctly. Most of them have answered it correctly. It's a straightforward question. So I put this question just to bring to light some important. So what is this? What you are seeing? This is actually what is called as a cortical ribbing. And what is this arrow mark seeing? This is called pulvinar sign, reverse hockey stick sign. This is seen in variant CJD. And we were discussing something previously. This is called Heidenhain clinical variant. That is, in our case, which we are discussing first, that is the posterior cortical atrophy variant. Sometimes CJD, if it is rapidly progressing, it's a close differential. This posterior cortical atrophy, close differential, one is actually Heidenhain variant of CJD, or it could be even DLB is also a close differential. So rapidly progressing dementia, we have to remember the code of vitamins. So vitamins, V for vascular, could be either a multi-infarct state or strategic infarct. What is strategic infarct? Is an infarct, a small infarct. Even a thalamic infarct can cause a memory impairment. Vasculitis, any AV malformation, cerebral amyloid angiopathy, posterior reversible encephalopathy, etc. Infections, toxics, metabolic causes, autoimmune, that is Hashimoto's encephalopathy, any encephalitis, autoimmune encephalitis like NMDA, etc. Carcinoma, iatrogenic, that is VITAMINS. So remember, like these all, any patient coming with rapid progression of dementia, you have to think of all this before branding it as dementia, Alzheimer's disease, FTD, etc., etc. Even Alzheimer's can have a fast progression. That also you have to keep in mind. So look for all these treatable causes or reversible causes, and look for this fast progression of dementia. So any clinical scenario you get in case of MCQs, any clues would be there, like CSF was done. For example, a patient with HIV. So sometimes the patient will be having PMLE. So that kind of scenario you may get. So a patient with multiple sclerosis, patient on such and such drugs. So that may be a PMLE. So that all we have to see. So which one of the following is not an alpha synucleopathy? So this is a very simple question. To relieve your tension, I have put this question. But this question you shouldn't miss. For very newcomers, I have put the question. So I'll tell you one thing. There is something called chronic traumatic encephalopathy also. Chronic traumatic encephalopathy. This could also come in your MCQs. Chronic traumatic encephalopathy. That is also a tauopathy. Chronic traumatic encephalopathy, which also presents as dementia. So that is also a tauopathy. Instead of Parkinson's disease, MSA, DLB, these all alpha synucleopathies. And you check, and the answer that one more MCQ option would be chronic traumatic encephalopathy. So don't get confused. That is a tauopathy. So keep that in mind. So next question regarding vascular, a higher Hutchinsky score is useful in diagnosing. So as we are dealing with dementia, we may get a lot of mixed dementias in our clinical scenario. So in case of mixed dementia, how will you differentiate between different kind of mixed dementias? So it is done with the help of scoring system. We have some other scoring system. Have you heard of Adam and Hakim score? That Adam and Hakim score is or a triad. Adam and Hakim's triad is actually used in NPH, normal pressure hydrocephalus. So Hutchinsky score is useful in diagnosis of somebody has some people, about 21% have answered NPH for Hutchinsky score. They must have got confused with Adam and Hakim's triad. So actually Hutchinsky score is a scoring used to differentiate Alzheimer's disease from vascular dementia. So it helps. So a patient with Alzheimer's disease, like kind of symptoms or a pathology, has mixed kind of dementia. We can differentiate vascular dementia from other dementias with the help of this Hutchinsky score. So if we look at the abrupt onset of this pathology, stepwise deterioration, whether there is fluctuation, whether there is risk factors, whether there is stroke, and focal signs, whether the patient has got weakness, reflexes exaggerated, etc., etc. and we can make a score of it. And if the score is more than 7, it suggests that the patient has got vascular dementia, and this is called a Hutchinson score. Now see this video. This patient, I just want you to see this video. So what all do you find in this patient? I am asking him not to touch anywhere, keep his hands still. So I'll show you the video again and again. He's unable to do his day-to-day activities by himself, unable to brush by himself. He has got rigidity, asymmetric rigidity over his right side, asymmetric rigidity over his right side. And now he has developed involuntary movements of his left side. So now you can answer it with your poll. And I am sure you will be able to answer without any problem. So poll is not working. Yes, you can start answering. Yes, everyone. Why do you think it is FTD? Because I told the patient is having asymmetric rigidity over the right side. So it is a kind of an asymmetric Parkinsonism. Only 2 Parkinsonisms basically have got asymmetry. One is the idiopathic Parkinsonism. The other one is the CBGD. So, and it is no history of DLB was discussed. So it cannot be DLB. And what we have seen there is actually patient was trying to get hold of the table when asked to stay still. As you can see, with the left hand, he is trying to hold of the right hand and also trying to get hold of the table. So it is a kind of a alien limb phenomenon. So CBGD also has got dementia, and that is memory impairment, corticobasal degeneration, and also has got apraxia. It has got very many features. You have to read through thoroughly CBGD. It even has got many features. You have to go and read through in detail. So this is an advanced question. This is the latest question. One of the advancements which came in May 2020. So with this, which among the following F18 tracers have developed and approved for clinical use by FDA for tau imaging dementia? So even if you don't know the answer or a difficulty in answering, if you have difficulty in answering the question and answer itself shows that the answer, if you see properly, you have got the answer in the MCQ option itself. If you see properly, read the question once again. I'll give you 1 minute. If you have proper, if you are able to sort out properly, see for the question, read the options, you have the answer. Even if you don't know anything regarding the options, you will be able to answer the question. Just see what is the clue. Actually, you are asked for tau imaging in dementia, and you have that tau inside the MCQ itself. So I'll just start the poll. Question number 19. Yes, simple as that. Actually, it has got tau within that. The other things, this floor to beta float, it's very difficult to read even, fluteminatum and all. These are all given in Harrison. These are actually amyloid imaging things for dementia. And this one was approved by FDA in May 2020. So latest in dementia also you have to get abreast with. So that was my point. And this actually, even if you don't know the answer, just read through. Even if you don't know the answer, just try to read through, and you have got a clue that there is a tau here and there is a tau here also. Rest doesn't have. So that is a clue here. So that is regarding imaging. So newer imaging techniques. So in case of Alzheimer's disease and other dementias, not much of imaging findings are there. Alzheimer's we have discussed in the last class regarding the imaging findings. So Frontotemporal was approved by FDA in 2020. First FDA approved molecule for imaging for tau protein. And these are the FDA approved for amyloid tracers. And that is our Alzheimer's disease. These three. And this one, last time I had discussed this cingulate island sign in FDG PET is specific for which one of the following disease. So this is just a revision question. So try to answer this revision question. Cingulate island sign in FDG PET is useful in distinguishing which of the following diseases. So if it is cingulate island is paired, so you at this point of time you don't know what it is, but this is being repeatedly asked, so you need to know it. But I'll tell you what it is. I have discussed this in the last class, so by now you should know it, what it is. So most of you are not listening in the last class. I hope this has been asked, so keep it in mind. At least by this is a second revision for you. Cingulate island sign and FDG PET is specific for which disease? This has been used in clinical practice to differentiate this disease from Alzheimer's disease, and also from posterior cortical atrophy. So in our case, it was posterior cortical atrophy. So to differentiate that disease also, we use this cingulate island sign. Yes, more about 46% have answered it correctly. It is actually dementia with Lewy body. So I'll tell you what it is. So there is preservation of this cingulate island. The cingulate gyrus, you know, it is the medial part, cingulate gyrus. So as you see, this brown, this is actually A part. This first box, what you see in the brain is actually the normal brain. And what happens in Alzheimer's disease, these green areas are actually not taking any, this actually is decreased in uptake. What happens is this is actually, this island is what we are talking about, this island. This island is called the cingulate island sign. You may not have understood right now also, but don't worry. This island of area which is spared in case of dementia with Lewy body is called cingulate island sign in case of FDG PET. So keep that in mind. And which is the least preferable time to give once daily dosing of donepezil? Last time we have discussed regarding all the drugs in case of Alzheimer's disease thoroughly. There were lots of drugs. We have learned, remembered the mnemonic Dr. TG. Donepezil, rivastigmine, tacrine, galantamine, memantine, etc. Of which tacrine is not used because of hepatotoxicity. So I asked you to read all the side effects of the drug. Which is the least preferable time to take donepezil? So try to answer this question. So we are giving donepezil once daily. So least preferable, not the most preferable, least preferable. Okay. Somebody must have mistaken as most preferable. So read the question every time. So actually, because the side effect is actually vivid dreaming, diarrhea, nausea, etc. Medication should be given in the morning instead of evening. So if you give the drug in the evening, there is more likely chance of getting vivid dreams. So that is the problem. So give it in the morning rather than in the evening. And other side effects you are supposed to know properly. So I think we have completed stroke and dementia. Wait for the dementia exam, which will be coming soon. Before that, I'll give you a few days to maybe 1 or 2 days to revise properly for the dementia exam, which will come soon. And study properly for dementia. It's very tough, a high yielding topic. Stroke and dementia are very high yielding topic. So we have finished both dementia and stroke. So if you go properly with this scheme, by the end of June or maybe May itself, we will be able to finish all the important topics, including pediatric neurology. So follow the scheme properly, follow this videos. So with that, I think we have finished this module 4. Read properly, Harrison and Bradley. You know the chapters very well. So thank you for your viewing and patient listening. Thank you, everyone. Thank you. So Mansiji, I think we have done. You can stop the streaming, YouTube streaming also. Thank you.